There we go. So rules for today. If you've ever done a workshop with us before, you know that we have rules because we're strict like that. No, we have rules. And the first rule is that we have to have fun. So we like to have fun. You'll see us as panelists. We joke around with each other. We like to have a good time. No other better place to be on your 12 o'clock lunch break than hanging out with us. And then the second rule is giving 110%. So we give 110% of our energy and witty humor over this hour. And we hope that you guys will give 110% as well. So that leads into our next one, being interactive. So thank you everyone for already jumping in, doing the poll, type in the chat, say hello, talk to us. I see somebody here. A wife forwarded you the email. Perfect. Yeah. So be interactive, chat with us. You know, that's a great way you can ask all your questions. We want to make sure you get answers to your questions. So definitely jump on that chat. And the fourth one is take action. So we really put on these workshops because we want to help people. That's why we got into this field. But that's also really what we're here to do today. So we want to encourage you guys to take action on your knee pain today. So jump in. You guys have the option of a discovery call. It's free. If you haven't been on these workshops before, we always offer these. So it's a call or a video call or a phone call with one of our therapists, and it's 15 minutes to get those answers to your knee problems. We're going to talk about kind of like the highlights, the spark notes, the top things, and we do hope that you take a lot away today. However, getting those specific answers to your issue for free, that's what that 15-minute call is for. So definitely book that. And then just for showing up today, we're going to give you the 5 knee braces for pain relief guide. So it's just a guide on when to use what brace and for what. We'll talk a little bit about the bracing today, but you guys will get that handout emailed to you. And here's our little, whenever I do these slides, I always put a nice little cartoon, little gingerbread man. I thought it would have been perfect if this was December, but sore knee, huh? Have you tried icing it?
I like it, Sarah.
I love a good pun, you know? All right, so spin the wheel. So just for showing up today, we always have a raffle at the end. So you have to stick around to the end, but everyone's name will be put on the wheel and we will spin it. And whatever name it lands on, you are playing today. Today you're playing for a free assessment from one of our clinicians in here. So you can actually get that assessment for free and start to feel better about that knee pain, hopefully as soon as possible. Awesome. So type in the chat. I said be interactive, guys. Rule number 3. Let's see it. Type in the chat. If you had no knee pain today, what would you be doing? So what would you do if you did not have knee pain? I mean, so many potential answers here. What would you do? Type in the chat. You know, pause for people to put their answers.
Running.
I like to think of myself as a young person. I haven't told you this, Michelle, but I had a moment this week. I went for my first run outside and I said to myself, my goodness, my joints are sore. I can really feel how hard the concrete is. That was the first time I said that out loud. So apparently something's happening.
Sarah.
I felt that impact. I was like, oh my goodness, like, whoo, it was rough. It was rough.
That's funny.
Awesome. Riding your bike more, longer walk afterwards. Going for a walk, and it is like prime time of year to get out and go for those walks because you're not like dripping sweat. Like you don't want to die. This past weekend was different, but generally, right, it's nice and fresh out there. Awesome. Thank you, everyone. Michelle, I'm going to go to the next slide. So we're going to jump right in here with the 3 biggest causes of knee pain. So the 3 things that seem to be the most aggravating that me and Michelle see the most in clinic. Number 1, osteoarthritis, OA. So for anyone who doesn't know what this is something that people are, you know, saying all the time, oh, my arthritis, my arthritis, my arthritis. So we have cartilage in our joint. It should look nice and smooth like it is on the one side. As we age,
Uh-oh, Sarah, you've just frozen there. Can you hear us? Hang on, I'm going to get them to bring you a cord.
is oh, Michelle. Oh, yes. Oh, maybe I'm back.
Can you plug into Ethernet?
People watching, give us 1 second. I can if it reaches this far. I need a dongle. Last time I plugged. All right. Someone would type in the chat. Can you see me? Am I frozen? Or someone type in the chat if you can still, if I've unfrozen for you.
Okay, Jess is going to bring you one in a sec, but you're back.
I'm
Yeah.
back.
Yeah,
Back
so she'll
in a-
bring you the dongle and you can plug in. But there's the next slide for you, Sarah.
So sorry about that, guys. So let's talk about today's osteoarthritic patient. So all the time you'd hear about like, oh, you know, it's this old person, you know, getting the OA. The biggest thing that we see is that this is happening younger and younger, sooner and sooner. We can start to see signs of this. And the sooner we, you know, kind of jump on it, the better we have results long term. So now we see this population, we're picking up the changes earlier. They're about 40, 50, they're active. You guys are active. You want to stay active. So gone to those days where we, you know, associate OA with, you know, it's right to the knee replacement and you can't do any physical activity. That's really not where we see this clinically anymore. We have this young population, they're active. You want to keep running, keep playing soccer, keep going after those young kids. Goal to just delay as much as possible the surgery and just prevent it from getting worse, prevent it from progressing. So we have the technology to pick these things up sooner, and we want to use that, and we get those younger and younger osteoarthritic patients.
Sarah, Barb is asking if you can just go back and explain arthritis again.
Yeah, for sure. So arthritis in our knee joint, we have this thing called cartilage. So think of it as like a nice lining, or it's a smooth surface that protects us from that loading that we have, you know, every single day, those impacts of the feet on the ground. And you can see in the healthy knee joint how smooth that is. So smooth glides, think of it like, you know, a well-oiled joint. It's nice and happy. Over time, that cartilage can break down. And what happens is we start to look like the picture on the other side. Now, this is quite severe. This is not, if you have OA, you're not assume this is what your knee looks like. But we start to lose that cartilage, and it starts to just be actually the bone, which is not really made to take that loading. And it starts to become more painful. And we start to have a little bit less of a joint space. So I always say to my patients with OA, I say that you have less of a joint space. So really that doesn't mean you can't be pain-free. It just means your wiggle room for bad movement is smaller. So I'm sure we've all seen like a teenager like sit down in this like horrible position for 5 hours, and they go to stand up and they just like pop right back up. And like, you're like, I could not get out of that position if I got there. Really, that's what it is that when we're young, our joints just, we can sit in the worst positions. We can be in bad posture. We can do bad things to our knees, and our body can just take it. And as we age, as we maybe get those degenerative changes, our wiggle room, our space for moving, not as biomechanically or not as perfect, kind of goes down a little bit. And that's why I was saying, if you jump to the next slide, we're seeing these signs, we're picking them up earlier, and we're seeing these presentations coming in younger and younger people. So I wouldn't say it's that younger and younger people are getting OA. I think it's more that younger and younger people are actually having it picked up sooner. So we can have that intervention, we can delay the surgery, we can, you know, have a longer or a better result that way. So next slide, Michelle. If this is you, type arthritis in the chat. So if you've maybe been told that you have knee arthritis, or if you suspect, you're like, hey, that morning stiffness, the worst with a lot of activity, that sounds like you, type arthritis in the chat. I feel like at some point, you know, we all get some degeneration. I always tell the story of, I had this 76-year-old man come in and he's like, yeah, like this thing's going on in my hip, and it was not related to the OA at all. He's like, but my imaging showed that I had mild OA in my hip. And I was like, you're 76, like mild's pretty good.
Yeah.
Yeah. It's
very true. I mean, it's pretty normal for anybody over the age of 40, 45. If you were to take an x-ray of, you know, of the joints in your body, you're going to see it in the joints, but it doesn't necessarily mean that you're going to be experiencing pain from it. But it's pretty normal. It's just part of normal wear and tear that happens to us with everyday life.
For sure. I've had a, you know, complicated sport history. And I always joke that even though I might not actively be in pain, if you took an MRI, my whole body would probably light up like a Christmas tree, because I my fair share of loading on those joints. Michelle laughs because she's treated my body. She's like, oh yes, oh yeah. So cause number 2, meniscus or ligament tear. So this is more commonly associated with trauma. So ACL, that's the one that everyone likes to hear, but we actually have 4 major ligaments in our knee. We can pivot, twist, there can be impact, we can slip and fall. There's a lot of different reasons we can, in a trauma, tear one of these ligaments or tear that meniscus. So the meniscus, you can see in this picture, it's that cushioning. So we kind of saw the cartilage on the top part of the joint, the cushioning softness on the bottom part of our knee joint is the meniscus. It should act like kind of like a spongy pillow to shock absorb and help that knee kind of stay where it needs to be. But if we kind of twist and grind on it a little bit in the wrong way, we can get a tear. Now, there's also a subset of tears that sometimes, if just years and years and years of us wearing on that meniscus improperly, we can also get a degenerative tear that won't necessarily come from a traumatic event where you like slipped and fell or anything, but it can be sore. And then the doctor might say, oh yeah, it's your meniscus. And it can come degeneratively as well. So this can sometimes present as if you had the trauma, you have that sharp pain, the knee feels unstable, it's wobbly. The meniscus, sometimes it hurts weight bearing, it hurts, the knee can get locking, it can click, it can kind of like, oh, my knee's stuck, I can't quite move it, or it might just buckle and give out of you with kind of a moment's notice. So we see this a lot. Again, this is more that traumatic presentation, but we do see them creeping in, sometimes degeneratively as well. So Michelle, next slide. If you think this is you, I want you to type in meniscus. So you think that you've had meniscus, or ligament if you've the ligament, but yeah, if you've had one of those kind of traumatic or degenerative issues, see someone meniscus, couple people. The meniscus, back in the day, they used to, cut the whole thing out. Now we're more in the era of like, no, it's important. Let's repair it. Let's try and save it, make it feel a little bit better to that meniscus. But a lot of people will have heard of, ACL surgeries, reconstructions, and all those things. So there's a lot of surgical intervention, but there's also a lot of physio intervention. So there's people who have a torn ACL. Michelle, do you have any non-surgical ACLs right now on your caseload?
Yeah, you definitely see them. And John was actually asking a minute ago, his question was from kneeling. And I think he was asking, can you get a torn meniscus from kneeling? And so like in a degenerative meniscal tear, yeah, you can. Like I've had people come in that, had done some gardening. And because of all the squatting and kneeling they did, it just tweaked the meniscus. And that's, caused the injury. So yeah, I definitely see them in non-surgical candidate people as well.
I see someone commented there, I have both OA and a torn meniscus. And yeah, you can have that. Sometimes you can have the torn meniscus as like an old traumatic injury, or again, that degeneration, right? So we're just wearing on our knee a little bit differently because we have those osteoarthritic changes. And then we get that meniscus that tears and gets irritated a little bit as well. All right, cause number 3, patellofemoral joint pain. So big word, what does it mean? Patella, kneecap, femur, leg bone. So kneecap, it has to actually sit in a groove on our main leg bone that comes down. So you can kind of see here, it actually shows it floating on top in this picture, but in all actuality, if you were to kind of look down your leg, there's a little bit of a groove and the kneecap sits nestled in there. So I just give my patients kind of this analogy. The kneecap sits in that groove and we want it to track right down the middle of that groove, okay? So if we're having forces that are kind of pulling it outwards or pulling it inwards, then we start to get some rubbing and friction versus it staying right in the middle of that groove, okay? So in that normal knee, it's just fine underneath there. Again, there's cartilage, it's smooth, got a nice like buttered up, greased up joint, it's perfect. But when we start to kind of have, again, that wobbliness for a multitude of reasons, we start getting that grinding or that irritation in between and behind our kneecap. So pain when you sit and keep that knee bent for like a long time, then you try to straighten it, you get that knee pain. Stairs is a big one, going down the stairs especially. People find that quite irritating. So this is a little bit more with activity, like using the knee, you feel that pain, that kneecap is kind of grinding and wearing down behind there. All right. So if you think this is you, type in kneecap. So if you think that this is your problem, if you're like, yeah, that sounds about right. That sitting in a car, people say like, oh, I sit in the back of a car, or you sit in like with your knees bent and you go to stand up, you're like, oh, it's quite painful. There we go. Kneecap. Yeah, no, it's not, it can be sharper pain too. It kind of grinds, you're like, oh, there it is. It gets really irritated. It's not a comfortable one. I would say this one is, without a trauma in like a kind of more younger middle-aged population, this is a big one that I see often. Some irritation related to that kneecap tracking. And Michelle, like it shows up enough.
Oh, super common. And I mean, sometimes you can have both, because that joint that's behind the cartilage, behind the kneecap, can develop arthritis. So you could have arthritis in that joint, but it's still the patellofemoral joint that's giving you the pain. So it's super, super common.
Yeah, and what you'll notice with this one is called patellofemoral joint pain, or PFPS. Pain syndrome is the acronym, and it's really, it talks about the pain, but it doesn't actually talk about the cause. Like this is one of those diagnoses where you're like, okay, so you have irritation behind your kneecap, and then as a physio, you know, great, you guys, people, you know, kneecap. It's like, oh yeah, you've identified that, but the biggest thing to identify is the why, right? That's how you're going to fix the problem. It's like, okay, it's irritated. Why is it irritated? It's the same thing, like, oh, I have a fever. Why do I have a fever, right? What is going on? Do I have an infection somewhere, right? Like we have to tease out those pieces of why we're presenting with that irritation.
Sarah, Anne is asking if this is also known as runner's knee.
I think runner's knee, jumper's knee, synonyms. So that is the patellar tendon. So Michelle, if you can go back a picture, you'll see the kneecap, and then you'll see there's a white string drawing that kneecap down. Perfect, Michelle. Look at that pointer. Got a real Vanna White going here. That is your patellar tendon. So when you have runner's knee or jumper's knee, that is actually a little bit lower than the kneecap, and it is the tendon that's there that gets irritated. So that's what's actually attaching that kneecap down. Awesome. So avoid the number one mistake that stops healing, causes re-injury, and limits performance. This is the number one thing that if we do not address it, people are just chronically going to have knee pain. And this is why I say this is our value add. This is why you come to physio. It's only focusing on the knee. So we'll go back to the example I just gave you guys, right? We have that groove, we have that kneecap, and it needs to be floating in the middle. Now, the reality is that if we want to control that groove, I told you guys that's our leg bone. So if we look at these three pictures, the middle one is more where we want to be. All right, we go to the one on the left, you can see how much that upper leg bone has shifted. And you can see that that's taking that groove that we need to be in, and it's turning it like this. So now all of a sudden our kneecap is against that outside. We're not keeping that bone in that groove nice and aligned. And you can see that that comes from our hip. So our hip is in a different position. And if you also look all the way down to the foot is also in a different position. You can see the opposite on the other side. So now the hips are a little bit turned out. Those feet are a little bit lifted up. Okay. And you can also see the changes that will have on the knee. I always kind of joke with my patients that the knee is the passive victim of the lower extremity. All right. So as much as we want to strengthen that quad and strengthen that hamstring and strengthen that calf, it plays a role. But I always give this example to my patients. So if down here, your foot is pretty much always connected to the ground. Okay. And up at the top, your hip is always connected to your body. Literally nothing can happen at the knee. You'll see both my wrists are always moving. Doesn't matter what happens, because it is grounded. When you move your knee, there is something going on above and there's something going on below. All the time your foot is in contact with the ground, always, which is like most of the day. I don't know, walking, standing, stairs, running, any sport pretty much. So next slide, Michelle. So the hip we said was a big piece, but here you see again, the foot is a huge piece, all right? So this old song, I'm sure Dry Bones, but a lot of people maybe have heard about this, them bones, them dry bones. So the foot bone's connected to the ankle bone's connected to the leg bone's connected to the knee bone. It's this old song, so many people have heard of it, and it's true. So again, we see this picture on the side. So if our hip is in the wrong position and our knee is now buckling in, right? You can see how the foot is also buckling, then flattening down. So if you have a flat foot, again, we just talked about it from the top down. Let's talk about it from the bottom up. So if you have a really flat foot, or if your foot is not absorbing the contact, right? You boom, boom, every step of every day. When you're running that foot, we're landing on it and landing on it and landing on it. And you can see how the position of our foot is going to, flat foot turns the leg in, turns the hip in. And now all of a sudden we're getting this huge load at our knee. All right, so we're going to jump in talking about, bracing, but really when we talk about bracing, we actually look at it as this topic of there's bracing and orthotics. So we don't always, necessarily think of an orthotic and putting it in that category alongside bracing, but it does, it goes hand in hand. So you can see here how if we're having a problem at the foot, it doesn't matter how much I strengthen your quad and your hamstring, doesn't matter. I can do manual therapy at the knee. I can make it feel better. But if you're going for a run and your foot is caving in and it is causing the entire force to rotate around the leg, there's nothing we can do in physio. There's nothing that can really, really fix that unless we fix that loading at the foot. Okay, so this is where we really look at that potential role of an orthotic or even just a gait assessment to say, hey, how much is my foot actually absorbing the load? Am I actually able to transfer that weight, have my foot contact the ground, keep my knee where it needs to be, keep it actually straight and tracking? Or is my foot just sending my knee in the wrong direction, causing these irreversible forces and changes to happen? So all this to say, if we just focus on the knee, if you're having persistent knee pain and you've only been focusing on the knee, you really, really need to take the time, look at your hip strength, look at your hip control, look at the foot, find out if an orthotic might help you, find out if we can just do even, we have an amazing chiropodist here, Brandon. I love him because he isn't one of those people who's like, oh, everyone needs an orthotic. I've sent him a patient and the patient's like, yeah, he says, I don't need an orthotic. I just need to strengthen my foot. It's like, yeah, sometimes your foot's good. Sometimes you need that orthotic. But just assessing hey, if I fix my foot and I'm going to get rid of my knee pain just like that. People have reported to me it can happen instantly. They're like, I get the right orthotic. Michelle, I'm sure you had stories like this as well, right? People are like, oh, I struggled with this pain for years. And then within a week of having an orthotic, it's better.
Yeah, for sure. And I agree. I don't think everybody needs one, but when you need one, it can make a big difference. It can be that missing link in the sort of picture of what's going on. Totally.
And at the end of the day, it just comes down to taking the time to ask the health professionals, do I need one? Have them take a look. You never know. You don't know until you know.
Yeah, absolutely.
All right, next slide. Does bracing help or hinder physical activity? So I don't know about you, Michelle, but I played rugby. And first off, there's limits on what brace you could use. But I constantly have patients talking about oh, but it's going to affect my agility, or it's going to help me, but I can't dance with it on, or can I play tennis? I can't quite cut. So I know that all the time people are like, is bracing really going to help me, versus actually hurt my ability to kind of do that physical performance? And for you, Michelle is our resident bracing expert here. She's going to chat with you about this. She knows way more than I do.
Yeah, I get that question all the time. And there's a couple concerns. One, I think, is performance, like you said. And then the other one is about the potentially damage that the brace could do, in the sense of I don't want to get, addicted to my brace or rely on my brace and have it cause weakness in my leg. And ultimately, the way, when I talk to people about that topic, I sort of say to them that, not all braces are created equally. And there are some braces that are intended to be used for activity and for sport. And there are some that are not intended for activity and sport. So first of all, you need to make sure that you get the one that's sort of meant for activity. And then they're, more streamlined, and they're made in ways that are suited for activity. And then the other thing is that you have to really you have to remember that a brace, if it's the right brace and it's doing the right job, it will help you remain active. So the positive effect of the brace is going to far outweigh the negative effect of potentially, if there is any negative effect. I don't know of any negative effects other than if it's a rigid brace, can cause some skin irritation, or it can be a little bit uncomfortable to wear. But the positive effect is that it allows you to be active. It allows you to get out there and do your thing, to do your exercise, to stay active, to walk, whatever it is you're doing. And that has a far more positive impact on the recovery of your knee. So it ultimately comes down to a few things though. And there's like the other overwhelming thing with braces is that there's a million different braces. There's so many different bracing companies, and within each company, they have a million different options. So usually when I talk to people about bracing, I talk to them about, like, you first kind of have to figure out, like, what's the diagnosis? Because you need to understand what you want the brace to do. And a diagnosis of arthritis compared to a diagnosis of a meniscus tear or a ligament sprain, you might want two completely different things out of the brace. So if you can figure out what the problem is, what the diagnosis is, that's your first step. And then from there, you kind of look at a number of factors to try to figure out what type of brace is best for you. And so you look at things like the anatomy of the leg, the shape of the leg. Sometimes, people are knock-kneed or bow-legged. And so some types of braces don't work for that type of shape of a leg. You take into consideration the activities that you're going to use it for. So if you're going out and playing rugby, like Sarah said, or you're going to be going for walks, two totally different uses for the brace, and it might sort of steer you in one direction versus another. And then you kind of within that have a number of choices, and the choices kind of range from like less bulky and softer, less rigid kind of braces, like what you see here, this gray one, or here, this black one on the end, where you can see it's sort of that soft, flexible material. And these braces are really good for someone if you've got like a painful, swollen knee that it's hard to walk. Maybe you feel like it's a little bit unstable and kind of giving way a little bit, not so steady on it. This is a great thing. It's a better version of sort of, you think of the old school tensor bandage that you wrap around your knee. This is, a better version of a tensor bandage because it's got different strengths of fabric in different areas to support you. And it has these like flexible supports on the side here that basically help to stabilize your knee, protect it, and it feels more supported. So you don't feel like it's, going to give way. It also helps that if you've got a bit of swelling in your knee, it kind of helps that swelling reduce it, so it keeps it under control. So this is the kind of, it's low profile, it's easy to wear under a pair of pants, easy to put on, and it's a great option if you just want a little bit of support. But if you need something more than that, then, let's say your knee you've just torn that meniscus and it's super painful, it's really hard to walk, then you might need something with a little bit more support. And that's where something like this comes into play. And this is not typically something that people wear long-term. You kind of wear it for the first few weeks when it's really painful and really sore. And then you kind of try to wean off of it as you go through physio and get the range of motion back and strengthen. You wean off of this kind of brace, but you can come back and start using this lower profile one, the compression style sleeve, as a more long-term brace that you can use ongoing. And then if you've got arthritis or a torn meniscus, there's a special kind of brace called an unloader. And the way they're designed to basically just change the alignment of your leg ever so slightly to take the bone on bone pressure off of your knee. So Sarah described how when you have arthritis, the cartilage kind of thins and you kind of start to get this bone on bone pressure between the two bones of the knee where the femur comes and meets the tibia. And so the offloaders basically just help to gap or offload the part of the joint where the arthritis is. Or if you've got a torn meniscus, it offloads the part of the joint where the torn meniscus is. And the idea is that by offloading, taking that pressure off just by a tiny bit of correction that the brace puts on your leg, it helps you to feel less pain when you walk, when you run, when you do your activity, day-to-day function. So you feel less pain, you're able to function more, less swelling. And there is actually quite a bit of evidence to show that these unloaders can actually help to reduce the need for surgery down the road. So these are actually quite proven, and there's a lot of research out there.
Michelle, somebody just asked which brace you're referring to.
Yeah. Good question. So this here is there are two types of unloaders as broad categories. There's like a soft unloader and a rigid unloader. And within that, like I said, there's many companies and many types of unloaders. This orange one here is an example of a rigid unloader, and it's got a special adjustment on the arm of the brace here that allows us to put that corrective force in, and that's what adjusts the alignment of your leg to offload. Now, there are also soft unloaders, which look more, I should have put a picture of that up, but it looks more like this black one here, where it's thinner, it's like a compression style sleeve that you slip on, but then it's got a really specific strapping mechanism that wraps around your leg to put the pressure on to offload the joint. So this would be a similar example to a soft unloader.
Yeah, honestly, unloaders are one of the ones, unloaders, I would say like people who feel hopeless get hope. There's a lot of like, there's so many roles to them. And, you know, I give the compression sleeve, or, you know, you give the ACL brace post ACL, and people do appreciate them and they have a role and they feel so good. But the unloader, I feel like, is when people come back and they're like, I can't believe it. Like,
yeah,
it's like the biggest wow factor brace. It's
pretty amazing. Like, I've had cases of people that said to me, like, before I was wearing this, I couldn't walk 30 feet without stopping because I was in so much pain. So, and, you know, not to sort of say it's that simple, because you still have to strengthen, like, this is one part of the treatment. You still have to see physio, you still have to strengthen. That's really important. But it is really amazing what an unloader brace can do with someone who's got like that degenerative meniscal tear or arthritis.
For sure, for sure. Somebody's just asking if your knee's otherwise okay, can a brace, is a brace a good idea for discomfort, like going down the stairs?
It can help. It kind of comes back to being able to first identify like why you're getting that pain, right? So if you're getting the pain going down the stairs because your kneecap, like Sarah was describing, your kneecap's not tracking properly, then you got to figure out, well, why is it not tracking properly? And there are braces, I didn't put a picture of one up here, but there are patellofemoral braces that actually help to put a little bit of pressure on the outside of the kneecap to stop it from kind of maltracking the way Sarah described. So if the pain that you're getting from going downstairs is because of patellofemoral problems, then a patellofemoral brace might help you.
Like I will say, like Michelle said, like it's one of those tools though where like it'll help you. You always need to wear the brace in case you find yourself coming into a flight of stairs, right? But if you look and actually, you know, diagnose the sole cause, it could be something simple like a matter of form or how you're going down the stairs. I mean, just we look at changing a few things and you can feel better there as well. Someone also was asking about, they say, will that also work with a MCL3 tear? I think they were talking about an offloader. What are your thoughts there, Michelle?
Yeah, so an offloader wouldn't really be indicated for an MCL tear, but depending on how you're presenting, what you're feeling, what your symptoms are, how your symptoms behave, like what makes it worse, what makes it better, when do your symptoms show up? Because if there's a bit of instability in your knee, then you might want one of these rigid braces because they do give you a fair amount of stability. So if you're noticing with activities that your knee just feels like it's giving way and unstable, or maybe there's a bit of pain, maybe a rigid brace like this, or there are other versions of these kind of rigid braces that are ideal for ligament instabilities or ligament tears. Also, like the other option, depending on how severe your symptoms are, a soft sleeve might be enough. The soft sleeve will give you, it doesn't give you rigid stability, but it does give you a better sense of where your knee is in space. And there have been studies that show that the knee helps to reduce. Do you remember that picture that Sarah had? I'll put it up here. Do you remember this picture here where your knees are kind of collapsing in? Oh no, hang on. You had a picture. Yeah, this dynamic valgus picture where the whole knee kind of collapses in. There are studies that show that even a soft sleeve helps you because it's signaling your brain as to where your knee is in space. You're able to control that inward collapse a little bit. And sometimes that can help with knee pain, whether it's ligament or OA, it's just better mechanics. So it helps to reduce the strain.
All this to say, there's so many different things a brace can do. And this is where, like, honestly, there's some braces where, like, I'm very confident in fitting. But when you have these cases that are nuanced, that's where Michelle's really, really great, because she knows these braces, and, like, she knows the braces that exist that I think most physios don't even know exist. Or like, oh, did you know this one also has a version of that brace? Or there's so many options out there. And I think sometimes people go, oh, a brace doesn't work for me. But it also could have been that you tried the wrong one, right? Maybe you need an offloader and you went for a sleeve. Maybe you had the patellar tendon brace. That's that small one, right? Maybe you had that, but what you really needed was something for your patellofemoral joint, right? So definitely there's pros and cons to all of them, but at the end of the day, it's about getting the right brace for whatever purpose you need it to serve.
Yeah, absolutely.
All right, so people, come on, type in the chat. Let's hear it. Who knows the answer? The number one mistake pain sufferers make. Give it to me. People who've been to our workshop before, you guys should know it by now. Number one mistake pain sufferers make. I'm watching the chat, see if anyone's gonna weigh in here. No guesses?
Oh, there we go. Anne's got the answer.
Yes. So, Michelle, next slide. There's 3 ways to approach pain. So good job, Anne. It is exactly correct. Ignoring it. Clearly, you are a regular.
Linda and Suzanne have brought up a good point too. Exercising less or not moving.
Yeah, honestly. Well, and that goes with number 2. So we say there's 3 ways that people can kind of, approach their pain. So the first one is ignoring it. It's fine. It's not happening. I'm just going to still walk my 5K. It doesn't matter if my knee's really, really sore. I'm just going to deal with it and whatever. And that is not the best thing to do. Now, the second way we handle pain is we alter it. So this is it. Exercising less, not moving. Oh, it hurts to walk. I guess I just won't go on my walking club anymore. Oh, it hurts to play tennis. I guess I just won't play tennis anymore. And we start altering our life. Or we go, oh, I can play tennis if I pop an Advil first. We alter the pain by having to ice it or heat it or Advil or Tylenol or use these medications to try and alter that sensation of pain, not actually dealing with it. Or option 3, handling it. So at the end of the day, the best option is to actually just approach the problem, figure out what's going on, and actually kind of handle it, right? Shall I even jump to the next slide? So what's next? If you guys remember, we had all these very exciting rules at the beginning that everyone's doing an awesome job following, by the way. Very interactive. I love it. And I hope you're having fun. I know I am. Remember the 4th one, though. It was take action. Okay. So really important. Again, we do these because we want you to feel better. So first thing, booking that discovery visit with us, actually trying to, just get to the root cause. I know some people were typing in the chat like, oh, I think it's a little bit of this, a little bit of that. What exactly is going on? Maybe, not everyone fits into a bucket. And quite frankly, every single case is different. So you might have the same, presentation on an MRI, but the causes and the factors that got you there, your lifestyle is very different than the next person's and the next person's. And a lot of it is lifestyle issues, lifestyle modification, little things like that. So making sure it's individualized. And that's why we like the discovery visits, because we can give you that individualized advice. And that's really what we want. And the second option is to actually start some treatment. So the discovery visit is 15 minutes. It's just over the phone or over Zoom, and it doesn't actually get you starting to feel better. So if you want to start feeling better, you can also just start treatment. Whether that's treatment with us, treatment with another physio clinic, if you guys know people, at the end of the day, like I said, we just want you guys to feel better. So if you have a healthcare professional, go see them. But the biggest thing, and Michelle, you want to go to the next slide, is what that care should look like. So I always like to kind of educate people on what proper treatment is. I was joking the other day that I went to the dentist, and my dentist told me I had a cavity, but I didn't feel tooth pain. I was like, okay, yes, I feel the cavity. Because how would I have the knowledge to know if there's actually a cavity? You just got to trust them. You're trusting that your healthcare provider is kind of, giving you the best of the best, but then not necessarily always the case. So I always want to educate people that proper treatment has 3 major pillars. The first one being education. I sit down with my patients. I'm like, how do you go up and down the stairs? Oh, how are you kneeling? Like, how do you do that? How do you do this? Oh, you tuck your feet underneath your chair for 8 hours while you're working? That's not good. education on how we can just move better in life so that we're not in pain. Manual therapy, so actually get hands-on, you know, modalities and machines have a role, but you should also just have quality time where your therapist is actually putting their hands on you and treating you. And the last piece is exercise, especially with knees. Strength goes such a far way. And if you're not doing strengthening based exercises, for majority of people, that should be a big piece of your exercise plan. And like I said before, we talked about the foot impacting and the hip impacting. So specifically for the knee, making sure whatever healthcare provider you're seeing, they're looking at your foot. Maybe you're getting that, orthotics or that chiropodist consult to see if the foot has something going on that they're addressing and looking at your hip. Maybe your hip's okay, but we always want to make sure that your foot and your hip at least get looked at because they play such a big role. Next slide, Michelle. So if you would like this free discovery virtual knee scan, okay, I want you guys to type discovery into the chat, okay? So this is, again, 15 minutes, it's over the computer or it's just a phone call, and we can give you that individual advice. So one of the therapists here will give you a call or set up that Zoom call and actually be able to get answers to your specific case and ask any questions you want because you got 15 minutes of our time and it's for free. So if you would like that, type in the chat discovery. All right. And then Michelle, next slide. The other thing, if you're like, no, Sarah, I don't want a 15-minute phone call. I want quality time with you. I want to start feeling better right away. You do the phone call. They say, yes, you should book. Then you book in. This is a very busy time of year. I don't know about your schedule, Michelle, but mine seems to always look like wait lists upon wait lists. So a lot of our therapists are busy. And if you're like, no, I would like to get in as soon as I can to start feeling better today, I want you guys to type in assessment. Okay. So type assessment in and we'll have someone from the clinic call you. We can book an assessment with you guys. And you guys can just get that full assessment, get an assess and treat, and right away start to feel better. Get that hands-on time. So type in the chat, type in discovery, type in assessment, or type in not sure. Maybe you're like, Sarah, I don't quite believe what you're selling. That's fine. Type in not sure, and I personally will give you a phone call. And you can tell me everything that you think should be different or up and down is up, and I don't care, but you can use that time however you want. So type not sure if there's anything I said or anything that's not clear, and you just want me to give you a phone call. I am more than happy to. So you can type not sure in. And
Sarah, John had a question. Can I ask now?
Yeah, I was just about to say, and now we're going to open the floor to questions. So Michelle, you're right on cue.
All right. So John says he gets lots of sounds from his knees. What does this mean? What does it tell him?
Ooh, I love this question. It doesn't tell us a whole lot. So a lot of people's knees do make noise. They can grind and crackle. A big question is like something's grinding in there. The degree to which it should cause concern, that is hard to tell. So that is like, we got to look at the rest of the pieces of the assessment. Some people, like I just, ever since I was a kid, my knee kind of cracks and grinds a little bit when I go up and down the stairs. I don't have any knee pain in my patellofemoral joint. I stay active. I try to keep my knees as healthy as possible. And sometimes it's just like, oh, you just have musical knees. Like sometimes that's just a piece of it. However, sometimes especially if you're getting pain with the noise, that's when there's a problem. So the noise on its own is like, oh, get it assessed, check it out, see what it might be going on. But pain with the noise is definitely not good and something that should be checked on.
Good. And Numa's asking, he's saying, my right leg / knee is loose or wobbly after a neck injury. Can you help with that?
After a neck injury. Yeah, so very different from all the things we've talked about here. All the nerves to our body. So I'm just rereading this. So all the nerves to our body, they come through our neck. So sometimes if we have some kind of nerve issue there, we can get weakness into our leg. That is 100% something that we treat. Not really one of the knee conditions that we chatted about at all today, but that is definitely something that we treat. It's about relieving that nerve compression and just, helping. As I would say, we didn't cover it today, but people will come in with knee pain. We're like, oh, it's actually your low back, or oh, it's actually your neck. And then you treat that area and you'll get distal symptoms or symptoms in that knee that are looking better.
Okay, here's a tough one. What percentage of meniscus tears need surgery?
Where's Dr. Wynn when we need
I know.
I don't know that statistic off the top of my mind. It depends on the type of tear. So there's some where it's like we call it a bucket handle, where it's actually like a flap. And then it's like majority of those need surgery because you have the risk of it progressing and getting worse. But also you can have just like a small meniscal tear that recover. And I would say like a fair share of people who are non-surgical meniscal tears. However, we work with a surgeon here who does meniscal surgery. So I also feel like we're biased maybe to say a higher percent needs surgery just because we see more surgical patients, Michelle. Like I feel like
yeah, it depends
population
on the patient, right? Like, are you a 20-year-old soccer player that has had a traumatic meniscal tear? Or are you a 45 or 50-year-old or 40-year-old, whatever, but older person, like not a 20-year-old, who maybe there wasn't trauma, maybe it was more a degenerative tear, and then it becomes a very different discussion. But one of the things, like the research that's come out in the last, I'll say 5-6 years, is showing quite clearly that if it's more of that degenerative type of tear, you're better off not having surgery. That the outcome at the 2-year mark, whether you have surgery or not, it's the same. So for the 40+ person who has a meniscal tear, surgeons, they're not rushing in and operating on those kind of meniscal tears.
For sure. So Michelle, I have to laugh. I say it's Brandon was maybe going to join us today, but I look at this and I see a question here. How often should orthotics be replaced? I've been using the same ones for over 30 years. It's a miracle I haven't lost one. First off, it is a miracle that you haven't lost one. I'm very impressed that you've kept them for 30 years. However, 2 years is what we recommend. It's not that you necessarily need a new orthotic. However, just like, our feet change with time, maybe our weight fluctuates, all these different changes. So every 2 years, you should see someone to get it checked on and make sure your orthotic is still working for you every 2 years. But I would say, what do you think, Michelle? 30 years, maybe a new one, maybe.
Yeah, maybe.
Yeah, it might be in time. Yeah. So 2 years is the answer there. But yeah, 30 years without losing one, that's pretty impressive.
That is very impressive. Tara, I see your question there that if surgery is needed, what's the wait time? So I'm not sure if you're asking about our surgeon here or just in general, but our surgeon here, I'm not sure what his wait time is. He only sees sports injuries though. He's a sports medicine surgeon. And so his practice is purely sports injuries. So if your knee injury is originally from a sports injury, you could potentially, be a referral that he would be able to help you. And then I don't know specifically what his wait time is, but I know that he, depending on the nature of the injury, is able to kind of expedite certain things. So if it's an urgent injury or surgery that needs to happen, he can make that happen. Something that's sort of not urgent, I don't know what the wait is. And then, outside in the community, it really just depends on the surgeon and what their wait list is like. But I know in general, it's not great. There's usually a bit of a wait for these kinds of surgeries.
For sure. All right, Michelle, should we spin that wheel? I'm gonna steal your screen share here.
Yep, I will stop. Tara, if you have more questions about that, feel free to reach out. Because if it's originally from a skiing injury, we can get you a referral that your family doctor would fill out, and we can send it into the surgeon's office, and he can see you.
All right, Michelle, can you see my wheel here?
I can indeed.
Awesome. Let's give it a spin. Ooh. Andrew J, but you have to still be here. Type in the chat. Let us know if you are still with us. Andrew J.
I don't see him, hasn't replied.
Say 5.
Maybe we should spin again.
3, 2, 1. Yeah, we'll spin again.
Okay. Suzanne,
are you still here with us? I'm here. Awesome.
There you are. Awesome.
Awesome. So someone will contact you if you requested a discovery visit. Somebody will contact you. And Somebody asked really quickly, would taping help as a step after using a brace? 100% yes. Ask us more on your discovery call. But yeah, thank you everyone for coming. If you ask for discovery,
one more quick question. Sorry, should one see a podiatric doctor first then? Who should make the general assessment first?
Generally, I think physios are some of the most qualified because we're physios. If it's for your foot specifically, you would want to see like a podiatrist. But we only see generally someone who is a holistic kind of treatment approach, and then we can assess and we can ascertain if yes, you need to be referred on or you need to see someone else, or we're kind of good at steering you in the right direction.
And yeah, like Sarah said, if it's more foot specific, then you can see the podiatrist first. Brandon, who's here with us, is really good at knowing, like if it's beyond his scope with respect to not just being the foot, he'll like make recommendations and give you guidance on who else you should see if that's needed.
Awesome.
Good. All right. Thanks everybody for coming. Any last questions before we wrap up?
Everybody have an awesome rest of your day.
All right. Bye, everyone.
Michelle, they say, well, yes. people can listen. This is unrelated. Are you able to save the chat? Because I am not.
Oh.
Click the chat, open it as a window. You'll see two panelists at the end of that. There's a ...
You mean just in the chat window on the right over here where I'm normally looking at it, or somewhere else?
Pop it out. Have it pop out into be. Why don't I come to you?
Yeah.
I just don't want to end the webinar yet.
It's okay. People are still filtering out slowly. Save the chat. Okay. Oh.
Where did we end it with the chat?
Yeah, absolutely. I just saved it here.
Oh, you did?
I think. Let's see.
Yeah, perfect. Don't email it.
Yeah, perfect. Okay, good.
Thank you.
No problem.
All right. Thank you, everyone.
Is there anybody still on, or are we all?
A few people still on.
Okay.
But I'm going to end this now.
Sure.